Well, good afternoon and welcome to Recognizing and Reporting Acute Changes of Condition. That's going to be our topic for today, and we are delighted to have so many different facilities and places around Texas joining us. And I'm Maria Wellisch, and I am a registered nurse and a licensed nursing home facility administrator and also certified in assisted living management. And I'm just delighted to have the chance to meet with all of you today. So welcome again. Today I want to mention to you as we begin that at the top of your screen you have some little icons. And your second icon from the left looks like a little bubble. And if you click on that at any time, that will tell us if you have a question. And don't be hesitant to use it. You can click on that. And type in your question, and Dayon, who's assisting me today, and Nino, who will be here in a little bit, will be referring those questions to me. So I want you to feel real comfortable. If you want to stop me at any time to ask questions, you're as much a part of this class as if you're in the classroom with me. For your edification, there is no one else in the class today. I taught it twice yesterday to a number of students here. We did a class in the morning and again yesterday evening, but it's a little bit easier when we do the taping without people in the room. So you don't have to listen to everybody coughing. So you have the little icon that looks like a bubble, and then also you see an icon in the upper left-hand corner that looks like a paperclip. And if you click on that later, you can download the evaluation of this program, and we're going to ask so that we can continue to offer these to you, that you fill those out, and if you call us, we'll either pick them up or send you an envelope to mail those to us in. But that's real helpful to us and very important. In one way, we get to continue to deliver these programs to you. So I'm going to go ahead and begin the program, and I'm going to ask you to send us, click on that little bubble, and let us know how many people are watching and where you're watching from. So if you're in Amarillo, if you'll just let us know that. You don't necessarily have to put in the name of your facility, but we're delighted if you would. And tell us how many people are there. I know we have folks who are out at Kendall House that are watching today, and I want you to send in, and Dayon will tell me what you're eating there, because everybody there always likes to tell me what they have on site to eat, because we don't allow food in this training center. So keep us informed and feel part of this presentation. I'm going to go ahead and start and tell you that all of the things that we're going to talk about today are as significant for a skilled nursing facility as they are for an assisted living facility. And the reason is that in assisted living facilities, we have a requirement for teaching our employees that they must and what do they need to report about change of conditions in residents. That's part of the training that we do as part of their orientation. In skilled nursing, we're held to FTAGs that require us to report change of conditions, to notify physicians and families, and we're very regulated in this regard. But many times we don't do a good job of teaching our frontline workers what they need to do. And nurses, for those of you that are watching this, remember to take this in the vein of being able to teach people who work with you. Well, what I want to start with is you cannot recognize changes if you don't know your residents. And that's really important because when we get new admissions, we usually find that most of our transfers out to the hospital come within the first month or at least within the first 90 days out. And why is that? And last night I had a class that was wonderful explaining to me the reasons why it is. And mostly it's the frontline caregivers that will tell you that when we have new admissions, we don't know when they have a change of habit in eating. We don't know about their change in bowel habits. We don't know about their sleeping. We don't know how they respond to certain medications. And so it's because these residents are so new to us that we have a difficult time and we see so many transfers to hospitals. And that's definitely something that we want to avoid. Transfers to hospitals, no matter how you look at it, are traumatic. They're traumatic for anyone, and especially for our residents, and even more so if you work with residents that are cognitively impaired. I have to say to you that no one, even if today somebody were to call an ambulance into this room, it's frightening. Even though I've worked in trauma for years, I've worked in emergency rooms before I entered long-term care, there is so much anxiety around an admission to a hospital. So just think about what that does, especially for our new residents joining us. But hospitalizations create a lot of problems for our residents as well. And I think some of these we need to talk about so that as we look at change of conditions and ways that we can prevent hospitalization, we also see what we're preventing for our residents. And that is skin breakdown. I want to explain to you that we all know that residents need to be turned every 2 hours in order to prevent breakdown. So it's no different if we put a resident on a stretcher and they lay in an ER for 8 hours and return to us. They're not less likely because they were in a hospital to have skin breakdown. In all essence, they're more likely. And the reason for that is that you don't often see people turning and repositioning people on gurneys or on stretchers. I want to thank everybody. Let me see that again, Dayon. I see right now that we have 10 people in Uvalde that have joined us. So those of you who haven't clicked on it yet, go ahead and let me know that you're here. And welcome, Uvalde. We're delighted to have you. So we talked about the skin breakdown and not being turned in the hospital. Increased confusion. Just think about the changes and the noises, the lighting, the people. All the activity that's going on there can create a lot of confusion and even delirium. Infections, we know any time that you go into a hospital ER, an ICU, or a surgical procedure, we increase opportunities for infection. And people don't usually go into ERs because they're healthy. That's not a norm. So people are going in there because they're sick, and if somebody goes in for a urinary tract infection, they may pick up an upper respiratory infection. So everything we can do to reduce these transfers is important. Under nutrition, when somebody is admitted to a hospital, is noted from when we transfer folks from long-term care or assisted living for admission. And the reason is, if you walk through our facilities, we know who has to be fed. We know who needs to use a straw. We know who will only eat certain things first, or you need to add a little dessert to something else to get them to eat the less palatable vegetables, whatever. That isn't happening in the hospitals. They're not staffed for that. They don't care plan for that. It's very difficult. And always we know that there's an increase in adverse drug reactions whenever we add new drugs to anybody's medication regimen. So these are all things that can happen with transfers to hospitals and things that add to the trauma of that. So, to begin, what is an acute change of condition? I think this is most important that people understand this. An acute change of condition is sudden. And it's so important that if we don't recognize some baseline changes in our residents' basic physical activity, their cognition, behavior, or functional domains, and they don't receive an intervention, this condition has the ability to result in a complication, a serious complication, and even death. That's an acute change of condition. Now, we're going to go through lots of these today, but I want you to know that we're not looking for something that's been happening over a year. Somebody who has had delirium for a long period is not going to have an acute change of condition. It might be new to someone new on the floor, and that's why we need to do a great job with documentation of what is acute and changing and sudden that has clinical importance. The goal of recognizing these changes, as always, is to allow the staff and physicians to manage residents at the facility and to avoid these hospital transfers or just even ER visits. Now, I want to mention as we start this program today that we are directing this at frontline caregivers. We also are bringing this to the attention of nurses for training the frontline caregivers, but also for being very attuned to listening to our employees when they tell us about these changes in our residents. So over what period of time do acute changes of conditions occur? Even though we say they're sudden changes, it can be very abrupt. Happening within seconds, something can change. A person who is sitting at a dinner table can choke. A person who's sitting at a dinner table and having a lovely conversation can have an episode of syncope. They can faint, fall on the floor. That is an acute change of condition. But it's also something that can happen over several hours. Somebody's starting to say, I'm experiencing nausea, and it's getting worse, and then it turns into vomiting. That's still an acute change of condition. And people don't think about acute change of condition happening over several days. What does that look like? This is when the CNA comes in the morning and says she just doesn't look right. and she says something to the nurse, she just doesn't look like herself, or she's not going in for bingo today and that's not like her, or she always loves to eat all of her breakfast taco, but today she didn't even want to touch it. And then you notice the same thing the next morning. We're beginning to see a pattern, but it's still an acute change from what we know about this resident. So that's sort of the time spans that we look at. Are there any predictable acute changes of conditions, things that we should be looking for that shouldn't be a surprise? That's for sure. When people have pneumonia, we've often seen associated delirium. And when we call the doctor, they need to know that they had the pneumonia. We might need to be careful in looking for some of these things happening, like with a recent catheterization. If somebody has a Foley inserted or they have to have an in and out catheterization, we might expect that if there was not perfect technique or there were some other problems, this person might develop a fever. Those are predictable acute changes of condition. Doesn't mean we don't report them, but we need to be looking for them. The other one that people often tend to not think about, and this is so important for me, and as we had a staff in here last night listening to this, they talked about this at length. When nurses administer new medications to residents, are we good about telling the frontline workers that we've started a new med? So let's say we've had somebody who has high blood pressure, and the doctor has ordered a new antihypertensive medication for this person, no matter what it is. We know with an acute change in blood pressure, high to low, we increase their chance of falls. Any kind of psychotropic drugs that we use, any anti-anxiety agents that we use, there are so many drugs that increase the potential for fall. Even a drug like Lasix has the potential, if you have a sense of urgency and you take Lasix for fluid retention, and then you have to go to the bathroom in much more of a hurry, racing to get to the bathroom so as not to have an episode of incontinence can cause a fall. So these are predictable changes of conditions, and these are the kind of things that we need to be looking at that we can help as a staff and as a team deal with, kind of be prepared for. A CNA cannot be prepared to be watching somebody if they don't know there's been a medication change. And this is really tough because med change happened all day long. But good reporting, good communication, we could sure look at this as being a possibility of reducing some of these conditions that are going to eventually take people to a hospital or significantly change their life. Okay, let's talk about reporting. First, you can't make any assumptions that a nurse or a doctor know the resident you're reporting about. And this is interesting because you can work in a facility and go down and say to the nurse, the resident in 334 just had a bad episode of nausea and vomiting. But the nurse may not know who is in room 334, and that's reality. This might be a new admission. This might be somebody who was admitted since the nurse was on duty last. We need to make sure that we're very clear that somebody knows who we're talking about, because that nurse needs to know, is it a new admission? If they don't know, what are some of the things that you can share with them? A full description of the change is so important when we're reporting, both for the nurse to the doctor, but also to the CNA to the nurse. I told the CNAs yesterday that were in classes with me that if you have a change of condition in a resident, to give a full description, the very first thing the nurse is going to say to the CNA when she comes up and says, she's just not acting like herself, or she feels kind of hot, or she's complaining of a headache, the very first thing the nurse is going to say is, go get a set of vital signs. Can you go take her blood pressure? I would say to you that this is something, if you're the CNA, that you're free to do right away and take those numbers to the nurse. The nurse is still going to do an assessment, but it sure does help her as she's going to respond to what you're bringing to her. For nurses, this is a major complaint by physicians that I hear repeatedly, and that is, do not call the physician without observing the resident yourself and having the client chart available. So if you haven't done the assessment and you don't have the chart there, you're going to have a frustrated physician. They tell me that there's nothing that makes them more angry than having someone call them and they're returning a call or someone calling them and the doctor begins to ask questions and they say, oh, hang on, wait just a minute, let me go get the chart, and they get to listen to the footsteps going down the hallway and coming back while they're at home waiting on the phone. If this is a call that's made after 10 p.m., you can imagine that that frustration level rises. So whenever you're reporting, make sure that you have as much information available as you're going to need. And what is that information? Well, we know that the physician is going to need the resident's name. I mean, these make no question about it, their age and their sex. Do not make any assumption the doctor knows who you're talking about. They have a lot of residents in assisted livings and skilled nursing facilities and in their private practice. They need to be reminded and helped too. What is the overall condition? Why are you calling right off the bat? What are the vital signs? Just give them. Physical findings, the resident's description of pain, if they have that. When was the onset? The doctor needs to know if there's been recent medication changes and, of course, about allergies, and so do you. So these are all important things before we get to individual situations and changes that I want you to be aware of. We go into a lot of depth about this in the reporting in a program we have called Geriatric Emergencies that's written for nurses. It really helps us with documentation, legal protection for ourselves, and the physical protection of our residents. So you might want to consider that, and I'll talk about that a little bit more at the end. The other information that is needed is diet, changes in intake. Especially when we talk about fluid intake and proteins. Somebody here, we're going to be looking at electrolyte imbalances, and the doctor's going to want to know about those dietary changes. And how are you going to get that information quickly? The CNAs are usually the first one who's going to be able to tell you what's going on with that. Current diagnosis, history related to the condition. And interestingly enough, almost everything that we're going to go over today, you're going to see deals with these BMs. Everybody teases me that I spend a lot of time talking about BMs, but it's part of our job here, and I'll tell you with aging, we know that we spend a lot of time talking about it. And we'll go into about the descriptions in a minute. I know you can't wait. All right, so always consider fluid and electrolyte imbalances no matter what the situation is. For those of you that haven't had a lot of training in this, this has to do with sodium and potassium intakes and what's happening in the blood, but this can cause so many different things that we look at in acute changes of condition. Acute infection is something to always consider. Potential drug reactions, recurrent falling, changes in mental status, behaviors, anorexia, and weight loss can all be a function of an adverse drug reaction. Some drugs cause a really horrible taste in your mouth, and it makes eating very difficult because everything tastes bad. And then you're going to see a weight loss from that. Behavioral changes that come from drugs that somebody is taking. A change in mental status. We know what the Beers list is for drugs of things that we don't recommend for seniors to take drugs. So let's think here just about a Benadryl or a Tylenol PM. And you know that if you work in assisted living, you always have the problem that people are out more. They get to go to H-E-B, they get to go to Walgreens, they get to go on some of these shopping trips. And we are not responsible for what they're buying, and we don't always know what's in their purse. And some changes in mental status, we always need to be looking at, is there some new medication that they're taking that we weren't even aware of, even though we may have all the responsibility for looking for self-administration of medication. I always am leery of these kind of issues that happen for us. So continue to look and watch for those adverse drug reactions. So the next thing is, whenever we're looking at acute change of condition is, do you know what your residents' wishes are? They need to be incorporated into every care plan in a skilled nursing facility or a service plan if you're somewhere else. And you want to have these documents, the advanced directives, very readily available. I'm going to tell you a story that just a week ago, I guess it was, maybe not even quite that long, I was over at one of the facilities nearby, and a resident coded in the beauty parlor. And I heard a code 1 called, and I watched this sort of play out. And I went down to see if they needed any assistance, and they were doing great. They didn't need my help. But I can tell you that the very first thing that the nurse said as they were pulling in and putting on the pulse ox and checking this resident's pulse and looking at the resident, she said, would you go get me the chart? I want to look at the DNR status. This is really important. For CNAs, there's no reason if somebody collapses that you can't grab the chart and bring it down for that nurse to be able to look at. We surely do not want to start and do something that goes against residents' wishes or violates their advanced directives. So these are all important things that sometimes we just don't think about when we're in a crisis situation and we begin resuscitation. That happens all the time. When EMS arrives, if we call 911, whether it be in a skilled facility or assisted living, it's going to be one of their first questions that they ask for. So, and if they're going to transport, they're going to want that out of hospital DNR. So I'm going to stop for a second here and ask you again to look at the little bubble up in the left-hand corner of your screen. I'd like you to click on it and send me a question or just a comment. And I want to know over at the AC, since we have some folks there watching, what are you eating? And you sure shouldn't be drinking. Okay. Dayon, are we hearing from anybody? Good. Great. This is wonderful. We're delighted that you're all with us. Dayon's telling me we have 3 more facilities that have joined us. So thank you for letting us know that you're with us. We are a team. That is the most important thing that you need to know. No matter where you work, no matter what part of Texas, no matter what facility, we all are needed to recognize resident change of conditions. And we need to respect each other's observations. This is imperative. I want you to know that the CNA's observations are important. We're going to talk about housekeeping, dietary, other folks as we get closer to the end of this. But remember, throughout this, we are a team. And it always concerns me when I hear a CNA report something to a nurse and the nurse will say, when did you get your nursing license? It frustrates me just as much when a nurse calls a doctor and says, well, thank you, doctor. That is not the response we want from each other. We truly want to be a team and respect each other's observations. So let's begin. Conditions A to Z. Every one of us will know that one of the situations that people suffer from in any type of life is abdominal pain, whether they're in a facility or out of a facility. But I want to tell you that as younger people complain of abdominal pain, and I'm not younger, but if I come in and say, oh, I have a stomach ache, I have to tell you I'm not nearly as concerned as I am with someone younger than I am with our older population when they complain of pain. There's a whole physiology of why seniors may not have a pain response the same as you or I would. And I want you to know we cover that as well in geriatric emergencies, but please accept from me that any time a resident complains of abdominal pain, we have to take that seriously. And we have to act. And sometimes we have to act very appropriately and quickly. Now, they may not complain of pain, so how are you going to know there's an abdominal condition? Those CNAs that were with me last night were telling me how often they'll see somebody's stomach get bloated. They're bathing these residents every day. They're changing them maybe multiple times in a day, dressing them. They're with them and they know what their bodies look like. So if a CNA goes to a nurse and says the resident's abdomen is bloated, they're very likely to know that's true. A rigid abdomen is one that is hard when you touch on it, and also you'll see sometimes with a rigid abdomen, when you touch the person's abdomen, they begin to guard. They don't want you to touch it, or you can feel them just sort of retract. That's a sign of an abdominal condition, and we want to report that. Constipation, we're going to talk about it throughout the entire time, but constipation, we all know that we're checking constantly for these BMs. And has somebody had a BM within the last 3 days, and are they constipated? But I want you to understand, thank you, I want you to understand that with constipation, people die from this. People die from intestinal obstructions, and we have to be observant on this constantly. We have a question. Oh, thanks. It's not a question. You all are really giving me back. Uvalde says that they're eating Domino's pizza. Yay, you're going to make everybody jealous up here. Nadine, thank you for your comments. We're appreciative. And Virginia wants to know why knowing about BMs is so important. She wants to know that because I talk about them so often. I'm going to do a whole class on this soon. And as we continue to go through, I'm going to give you more and more reasons. But first one we just mentioned was with constipation, you can die of an intestinal obstruction. Report changes in appetite and know that older adults have the potential to die from abdominal conditions, much more likely than if you're a younger person. In the older bowel, we see torsions of the bowel, we see diverticulitis, we see ruptures of these little vesicles. So all of these things are important. So the most significant thing I can tell you to remember here is if somebody complains about their abdomen or you notice any of these changes, these are must-act situations. Agitation is very interesting. Agitation we begin to look at as behavior changes. And in many times, I want you to know, in the cognitively impaired, rather than being part of the disease process of dementia, agitation can actually be that somebody's in pain. So we need to always evaluate, especially in the cognitively impaired, pain. I don't even think that all of us recognize our own pain, that we might get agitated if we have a headache, but we don't sense it as agitation, but we are. So pain is always a thing here, but more importantly with agitation is poor oxygenation. If people are not getting enough oxygen, they become easily agitated. It's part of the fight or flight syndrome. So when you think about that fighting, you think about getting very, very agitated. That can be just because somebody doesn't have enough oxygen, and we don't always think about that. We just tend to think about it as behaviors and what upset them. But we need to look at the physiological actions that are going on. Appetite, we say that any changes need to be reported. And this is because a change of appetite can represent so many different conditions. So while we're under the A's of things to report, we're going to see this when we get down to dental conditions, many other things. But that one is extremely important. But yet, we don't put as much emphasis sometimes. I know that we report in skilled facilities what percentage of the food they ate or how many points did a person have. But are we really looking at change of appetite, change of consumption of food? Bleeding, any kind of bleeding, rectal bleeding, nasal bleeding, any part of the body needs to be reported immediately. But what's really interesting is sometimes a CNA will clean up the blood or a housekeeper will clean it up before they go report it to the nurse. We want the nurse to actually see the blood. We want to know if it's bright red. We want to know if it's dark. We want to know if there's any clotting with that bleeding. So we have a lot of things with bleeding that need to be assessed, and that needs to be done by the nurse. And I don't mean in active bleeding that somebody wouldn't apply pressure and try to stop and do something then, but I'm saying for any type of bleeding, the nurse needs to see it. We don't want to talk about a bloody stool if somebody has a BM with blood in it and flush it away and then go tell the nurse. We want the nurse to be able to come down and assess the amount so she can report that to a physician. And sometimes we forget that. Blisters. Very interesting. Little tiny blisters, just one, just two. Sometimes a nursing assistant will go report a tiny little blister to the nurse, and the nurse might ask a question or two and might not get down to do the assessment herself. We might talk about a little insect bite, but I want to tell you that little insect bites, and do we have insects in assisted living and skilled nursing? We do. As much as we implement pest control, we still have insect bites. We have folks that have little tiny spider bites. I've read about facilities that have had an infestation with the red ants. We all hope this never happens to us or our residents, but it does. So insect bites for sure need to be reported because those are very susceptible to infection with MRSA. That's the methicillin-resistant Staphylococcus aureus. We also do a program for contact hours on MRSA and VRE. But I want to talk to you about blisters can be a response to a drug. This can be an acute drug reaction, and people can go into anaphylactic shock. And if that little blister is identified and a nurse can begin to see a pattern and call a physician and get someone treated if they've had the onset of shingles, we can eliminate post-herpetic problems so much when we think about how much pain can be involved. after this disease process or even during it. So we want to make sure the sooner we can diagnose that and have it done by a physician, the sooner we can start some antiviral agents to reduce the length of that disease process and especially the postherpetic pain that comes later that can just be debilitating to many of our residents. So blisters have to be looked at. C to D. We're moving along. I feel like I'm on Sesame Street that I could do that. Coughing is always important to report. And so when somebody comes up and tells a nurse that the resident is coughing a lot, I want the CNAs to feel comfortable to be able to say to a nurse, it hears like they're wheezing, or it sounds like there's a cat in their chest, or it's really rumbling when they cough, or it sounds really deep. We're not expecting any of us to be pulmonologists, but we should know what that cough is sounding like. Because when the CNA hears the cough, if she can describe it, or if you're the CNA and you can do a good job of describing it, it doesn't mean when the nurse goes in that resident is going to cough. So we need your help, and you need to trust yourself. You're able to make those observations and give yourself credit that you know the sounds of different coughs. Chest pain, always. That we don't even have to spend time to talk about. This one is very important, and that is, and this has been written up in AMDA guidelines, that's the American Medical Directors Association, about reporting complaints. Resident complaints, family complaints, sitter complaints, visitor complaints are reportable incidents. Doesn't mean that you'll have to call the doctor or the family immediately, but everybody should be reporting those complaints, and they need to be taken to the appropriate person. If it's something about the environment of the room, something about the safety of a bed or a wheelchair, those complaints need to be taken as seriously by anybody who's placed it as any one of these conditions. I always say that when I had young children and I would go to the pediatrician, I always felt like I knew my child the best. Even though the doctor might not always see what I saw, I always felt like I knew, and I was usually right. And I think this is the same situation for sitters and visitors who are friends that have known these people for years. If they have a complaint or a concern, we need to listen, report it, document it, and act on it. If you have any questions about that, let me know. Confusion. That's another one that needs to be reported. But if somebody's confused all the time, that is not an acute change of condition. That is simply maybe part of their disease process. But somebody who was not confused yesterday or an hour ago or ever that is suddenly confused, this can be the sign of many things. This again could be a sign that they're not getting enough oxygen. This can be a sign of a urinary tract infection, or it could be something even much more serious. And we'll get to those when we get to some of the head injuries and head-type problems. Convulsions, of course. Constipation, still under C. Remember, you have to report that. If by the time you don't finish this program, that'll be one thing you don't forget. Dizziness. Residents complain of dizziness. They'll say, oh, I feel dizzy. Do we take that seriously? Dizziness can be a sign of an inner ear infection. It can be an inner ear disease, like Meniere's syndrome. There are so many things that are a problem with dizziness. Low blood pressure. It can be increased blood pressure. It can be a response to a medication and adverse. But what usually happens from dizziness? I hope you're answering this out loud wherever you're at. Falls. Falls are the most common thing that happens after somebody has a dizzy spell or feeling dizzy. It's a precursor to a fall and something that we can prevent. All right, E through G, earaches. The one reason I put earache on here is, number one, all of these come from the American Medical Directors Association of what they want you to report. But I think earaches are some of the most miserable problems that you can have, and they should be reported and treated. The pain, but a doctor needs to be aware of this. They can lead to very serious infections. Many times in our residents, we don't think about this when they complain about an earache, and that is that they wear a hearing aid, and the hearing aid may have rubbed a certain place and gotten the inside of the ear infected, or maybe having a lot of pain there from irritation. So we need to make sure we report those. Edema is sort of one of the most interesting things because we all have to be looking for this, but this is the one thing that the nursing assistant is most likely to spot even before the nurse. The reason being because they're bathing them. That's number one. Number two, because they're putting their shoes and socks on them in the morning. Number three, they're helping them to wash their hands. We're going to usually see edema in the feet, in the legs, in the hands, but we often forget with edema to look at the periorbital edema, and that is swelling around the eyes. Edema can come from multiple factors, but let's think about why this is so important. Edema can be a sign of congestive heart failure. Edema can be a sign of too much salt intake, high sodium levels. Edema can be a function of renal shutdown. These are all very serious conditions, and edema is the body's one of the first responses that we need to be reactive to. Eye pain, I'm moving on now, don't mean to go too fast for you, but eye pain is something that is so important to respond to because there are certain conditions, and we're going to actually have a geriatrician who's going to be in talking just about the eyes in the not too distant future, and we'll let you know when that is. But some conditions, if we don't treat immediately, and I mean immediately, a person loses their vision. Something like a detached retina is something that may be able to be reattached. And if this can be done for someone, and there are conditions with glaucoma, that someone can lose their vision if we are not responsive and we don't get hold of an ophthalmologist or a geriatrician immediately for referral for this. This is one area that I want to tell you, when you see red eyes, people talk about strange sensations in their eyes. We are not diagnosticians. We are not ophthalmologists. And just recently somebody said to me, oh, she just has pink eye. I said, how do you know? And she said, oh, I called the doctor and I told the doctor. You know, there's a lot of conditions with the eyes that we are not diagnosticians. We want someone else to see these folks, so make sure you report these and get someone to come in and see them. We do so much training on falls. I know all of you have been through this. It's what we all fear, deal with on a daily basis. We do an entire issue on this as well, but every fall has to be reported. Every fall, whether it was observed or unobserved, has to be reported and requires an incident report be completed. Like I said, we could do a 2-hour session just on falls, but you just can't tell people enough when a resident says, no, I didn't fall, I just slipped out of my chair, or no, I didn't fall, I wanted to sit down. This still needs to be reported because there is still embarrassment with falls. When I fall, the first thing I want to do is get up and pretend it didn't happen. So I want you to know that we can't focus on this enough, but that's another whole program. Interestingly enough, with fevers, seniors don't always mount fevers as quickly as a younger person will. And we need to recognize that by the time a senior has a fever, we usually are into a very serious situation, and that needs to be reported to a doctor immediately. Fever can be a sign of impending sepsis, of which somebody can die from. So once a fever is there, and if it's a very low grade, somebody usually just runs 98.8, 99.9, and they're getting up to the 99.9 area. We want to be repeating that frequently throughout the day. We don't want to dismiss any elevations in temp because this just isn't normal in seniors. Head injuries are something, of course, that we would report. I don't think there's any question that anybody would even think about that. But I think what people do miss is that a lot of times residents do fall, do get themselves up, and then begin later in the day to complain of dizziness, other things, and we may never even have known they had the fall. So anything that mimics a head injury, we need to look at. Confusion, disorientation, dizziness, more falling. We need to be doing neuro checks and calling the doctor. How many people watching this program have had a headache in the last month or two? If you work in long-term care, you've probably had a number of headaches in the last month or two. Headaches we may just have because of the changing weather. But headaches can also be a symptom of sinus infections impending. They can be a sign of high blood pressure. intracranial pressures, subdural hematomas, so many things. A headache should not be dismissed or forgotten about by a person reporting for a couple hours. When a resident complains of a headache, the nurse should not just say, give her 2 Tylenol and let's watch her. A headache should be looked at. You should go in and get a blood pressure. You should look at the pupils. You should do an evaluation. Spend some time talking to the resident. Ask them if they've had a recent fall. Talk with them more about this. Somebody who's had good hearing all along that has a sudden hearing loss, reportable. Hematuria is blood in the urine. I don't think there's any question that someone would report that immediately. However, again, what happens is somebody will flush the toilet or throw out the diaper and not allow the nurse to make the assessment before calling the physician. We want to make sure that what we're doing is giving the nurse an opportunity to see this blood. So anytime we see blood, we want to do a more thorough assessment. Incontinence is part of our life in assisted living and skilled nursing, no question. It's sometimes the only reason that somebody is admitted to an assisted living is incontinence, and the family thinks it's time now that she needs or he needs more help. Incontinence that has been persistent or over time, or just an isolated incidence of incontinence because somebody may have coughed hard and had some pressure incontinence, those kind of things are not acute reportable conditions. However, incontinence, when somebody has been totally continent before, can be the telltale sign of a urinary tract infection and cannot be ignored. There's also some pelvic floor disorders that happen in people that create incontinence that we need to help these people with and make changes very quickly. So I want you to know when to report those. All right, how about itching? Almost all of us have an itch now and then. I have an itch, it's Friday afternoon to get home. But I want you to know that itching has many implications. We know that you can have a drug reaction and have itching, which can lead to a very severe situation, again, of anaphylactic shock. Itching can be, people tell me, from scabies. We don't know anything about that in our positions, do we? Itching has so many different complications associated with it because if people start scratching, even if it's just dry skin, we want to look at cutting fingernails so that people won't scratch, create bleeding, make an open area that can become infected. So lots of things that can be a precursor here, but action that we need to take. But in some cases, we actually have to call the doctor, and after we observe, if a CNA came to me and says somebody's really itching a lot, this might even be a case for EMS to be taking somebody out. Let's see, I've got some notes, and I really appreciate you joining me because it makes it so much more fun for me teaching. And it says, Kendall is celebrating employee birthdays today. Oh my gosh, they're having homemade chicken and dumplings and tomato pie. I don't even know what tomato pie is, but I want you to save me a piece. And happy birthday to everybody at Kendall who's having a birthday. I have another question, and you never have to use your name. This says no name, and when you call it, that's why I love these, because you don't have to use your name. It says, is it appropriate to report all falls, even those that are uneventful, those that produce no significant symptoms or evidence of injury? Okay, let me answer that question for you. Yes, yes, yes. Every single fall must be reported. The reason behind this is multiple, and I've sure been doing this for a long time. You would not call a doctor in the middle of the night if there was no evidence of anything. If you've done an appropriate assessment, you've been complete, but very first thing in the morning, or a fax, yes, you have to notify, and the family must be notified of all falls. The reason is that a person may not show an injury immediately, and a very good example of that is an unobserved fall. It says even those that are uneventful. Well, if somebody falls and they're just fine and they say, no, dear, I'm okay, did you hit your head? No, I didn't do anything like that. They may not even remember they hit their head because they may have been unconscious for a few minutes or longer or shorter. A subdural hematoma can take days, weeks, even a month with a slow bleed to show something. And then if there is evidence that there was a fall. every single fall is considered reportable. And another reason for this is looking for trending. A resident may have a fall today and not another one for 3 days, and then not another one for 3 days, but you may begin to see a pattern or a trend as to why is that person falling. Things for falls can be as simple as they'll say, she just slid off the bed. Interestingly enough, I was on a couple of years ago, I was consulting with a facility, and they had a resident who was having falls, and I looked at that one case, and the resident was just sliding off the bed. Her bedspread was one of those very slippery kind of materials. It was just very slick, very silky, but it was taking her right down on the floor. She wasn't being hurt, but she could have been. But so I'm going to say absolutely every fall should at least have an incident report made about it. The physician should be made aware that a resident is falling. They may do nothing about it, but you want to be very sure to protect yourself on that. So yes, that would be my response. And if you have more questions about that, please feel free to ask. Let me stop at this point and tell you that on anything that I'm discussing, if you have more questions, you have an ability at any time, whether it's during this program or later, to email us. And you're always free to email us at info at mmlearn.org, info at mmlearn.org. You can always come back onto this program, which will be put up, and you can watch this on demand at a later time and ask questions. And let me give you a phone number, and that's 210-734-1070. You're always free to call me if you have a question, because this isn't just training for a day or training for an hour. We're committed to getting you the answers that you want. The most frequently used resource that we have to guide us in these decisions is by AMDA, the American Medical Directors Association, who talks about these types of events, and I'll be glad to share that literature with you as well. You can order those even if you're not a member. They tell you what's reportable immediately, what's reported the next day or as soon as possible, and what's reportable with the next doctor's visit. They're wonderful at giving you great advice, algorithms of what to use. So these are great questions, and I really appreciate that, so thanks. So we'll move on from H and I, and we're going to move to L through N. How are we doing? Is everybody hanging in there? Why don't you click on that tab and tell us how many of you are still with us. It kind of keeps you engaged with us. So if you can stop putting the chicken and dumplings down for just a second at Kendall, let us know how many people are still watching with us, and from Uvalde and all around. So we're delighted you're with us. L through N. Lab reports that are abnormal, nurses immediately report to the physicians. All lacerations, I don't worry about that. How about medication errors? All med errors, minor or not, must be reported. That means that these have to be put into an incident report form on a med error report form. Families must be made aware that a med error was made, and a physician must be notified. If it wasn't ordered and it was given or it wasn't given, these are reportable, and those are considered incidents. Memory loss can be a part of the disease process associated with dementia and many other conditions, but not new onset memory loss. New onset memory loss that comes on very quickly can be things that have to deal with thyroid conditions. It can be vitamin deficiencies. It can be many kinds of things that have to do with even our albumin levels, our electrolytes. So memory loss is a reportable acute condition. This is why you've got to know the baseline of your residents, because if you don't know where they are usually, you're not going to be recognizing those things. Nausea absolutely must be reported. It isn't because somebody is nauseated, just that nausea in and of itself is not something dangerous, but it sure can be an indicator of something happening. I was in a facility not long ago that within the course of 2 hours, 14 people had nausea. We have to immediately look, is there a food issue? Is it a viral issue? Is it something more serious than that? So you want to make sure that all nausea is reported. Last night, I didn't have, but actually I had no one yesterday in any of my classes that were CNAs that knew what nocturia was. So I'm going to leave this one and see if anybody can write into me and tell me what nocturia is. And day on, you're going to be responsible for reminding me to go back to it. Okay? And they're going to tell us what nocturia is. I'm just keeping you engaged to see that you're listening. Nosebleeds can be significant because this can be an indication. They may have something, a capillary break in their nose simply, from picking their nose, from a sinus infection, but it also can be a real serious indicator of other conditions, and that would be high blood pressure. So those are some things to report. How many times between falls and pain? I think this are the issues that everybody, every surveyor, everything that we're dealing with is dealing with pain. It is now considered the 5th vital sign. We do 2-hour programs on pain. Pain is the most undertreated condition in long-term care facilities. It is sad to me to think about that we're not treating people's pain. I spent some time last night talking about, in regards to pain, that we do a lot of worrying about addiction, talking about dependencies, putting our own values on other people's pain. I know you've had a lot of training on this, but I want to just say to you, pain is whatever somebody says it is. We do need to set pain goals for people, what is tolerable, what is not, and we have to help people with pain. This is a great opportunity for training, and I love teaching to this, but we have to always respect the pain situation. Nurses, if a CNA reports pain, you have to follow up. Med aids, you know what your license allows you to do and not do in regards to pain medication. But of all the things, this is so important, and it's so indicative of so many other things going on in these dear little bodies, so please pay attention to that. Pressure ulcers always have to be reported. Now, let's talk about pulses. Normally, a CNA will take the vital signs, and if a nurse takes the vital signs, I don't have any concern with this usually, but I will say for a CNA, trust yourself. You have every right to go to a nurse and say, the pulse doesn't feel regular. It feels funny. There's something about her pulse isn't right. Bump, 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 bump. It's very it just feels regular. And all of a sudden, while you're counting the pulse for 15 or 30 seconds, it goes bump, 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 and then it goes back into a normal rhythm. Or it's bump, 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 bump. You can say that. You can feel that. And there's nothing wrong with reporting to a nurse and say, the pulse is irregular. It doesn't feel right. I'd like you to go down and take her pulse. Don't be afraid to trust yourself. You can feel that. I think so often our CNAs and CMAs underestimate their own ability to be able to recognize these important changes. So I trust you, and I want you to know, be ready for the nurse to go down and the pulse to be perfectly normal. That is not unusual. But still, if you found it and you report it, it'll make that nurse more aware that, yes, there could be something going on. And we can even put it into the chart. CNA reported irregular heart rate. The doctor can listen and take more, may want to order an EKG. But trust yourself if you're the CNA. Don't think that you can't take that forward. That is not, and don't let anybody say, what do you think you're being a nurse? No, I'm being a good observer, and I'm being an advocate for the resident. Puncture wounds, I can't imagine somebody wouldn't report that. Respiratory rates, again, I want to talk about somebody who's breathing too fast, somebody who seems to be breathing too slow, very shallow. It means they're breathing, they're just not getting in good deep breaths. Did you know that the #1 symptom in aging folks for a heart attack is shortness of breath? #1 complaint. The #1 observable thing. It is not going to be a complaint of chest pain. It's not going to be radiating pain usually. They can have all of those, but the #1 complaint in older folks is shortness of breath. So if you're taking respirations, you want to be looking at this. This is not something to just take lightly. This is so important. So we'll get to shortness of breath when we get a little bit farther into the ESSA, so I won't spend more time there. We've talked about rashes. We talked about convulsions and seizures. And skin tears, all skin tears must be reported, every single skin tear. and that must be documented, and I think we all know that one. I'm trying to hit on the ones that we might not be as familiar with. We have a lot of S's. So don't go to sleep. These aren't Z's. I want you to stay awake with me. Shortness of breath, I'm going to go back to just for a minute. We have a lot of people who live with us that have chronic obstructive pulmonary disease or emphysema, other issues that cause shortness of breath. But we need to know about pursing of the lips, that breathing, that changing so that they can get more air in and how they breathe. We need to report anything at all that has to do with respirations or breath because this is so significant and needs immediate treatment. If you notice a splinter, and our residents do get splinters, they surely do. We have wood items, they have furniture in their room. If you see a little splinter, you don't want to ignore that. Those things can fester up and can become ugly, and we need to report those. Unfortunately, on this issue, this is one of the most underreported issues that we have in aging, and that is suicide potential. Don't think that elders in nursing homes, assisted living, and independent living do not have the potential for suicide. I've worked at 2 facilities where we have lost a resident to suicide, and it is such a sad thing at any age. But I also want to tell you that we are the ones who hear those words coming. It is, I don't have any reason to live anymore. I'm ready to go now. Those may be just passing remarks, but we need to take them very seriously. They need to be reported to the nurse. The doctor needs to be made aware, the social worker, a family member. We need to be addressing depression in our residents. There's so much we can do to make life better as we deal with person-centered care. But I have to say we need to listen and not just say, oh, you're not ready to go yet. Oh, we need to take these thoughts seriously and recognize there's so much behind that. This is a great question that I asked last night, not because I asked it, but it's an important question. Whether you're in independent living, assisted living, or a skilled nursing facility, what is often the single most common sign that we have that somebody has dysphagia or a swallowing difficulty? The answer to that is that when somebody is coughing when they're getting a glass of water or a thin liquid. Somebody who starts that coughing, I hear this a lot when I go into independent living, very frequently, thank you, very frequently I hear that coughing going on. In assisted living, many times I'll go through and I have to show people and point out to them that they're not coughing when they're eating their pudding. They're not coughing when they're eating mashed potatoes, but as soon as they're taking a sip of the liquids, they're starting to cough. It's one of the initial signs that we have, and that's why we thicken liquids and we have all that. You must report that when you see that. And so when you hear about coughing, and we had that back in the C's, that was really important. This is another time to be very aware of that. And if you do work in independent living, this is something we need to bring to the attention of the resident. We can help folks with this problem, so in most cases. I want you to know that I will not say this one, but we have one of our folks that's still watching that has no incontinence and is not itching. I'm not sure I believe it. I'm going to do a check when I leave. Valdi. Oh my gosh. In one of our locations that is watching this at a distance, they say that they've had 2 residents discharged from the hospital that have not been bathed for days and even in the ICU. When we talked at the very beginning of this class about wanting to not have folks have to go to the hospital, this is exactly why. It is a different world that we're living in today. I have to tell you the attention and care for seniors is something that everybody needs to learn. I'm surely not going to disparage any hospital or any nurse, but I want to tell you nobody takes better care of our residents than we do. Because we know them, we love them, we have a relationship with them, and even if they're a difficult relationship, I see our employees, and I bet yours, taking impeccable care of these folks because they've been entrusted to us. It's not just someone that has come in with a condition. These are people with families and lives. We've seen their pictures, heard their stories, so it doesn't surprise me. but it is a great comment for you to make, to share with us, is why we want to look at all these conditions and keep people in our own facilities as long as possible and not have to have them sent out to the hospital. Thanks a lot for still being out at Chandler. We appreciate you hanging in there with us and watching. They still have 10 folks with us out at Kendall, which means everybody's learning how to use these controls in Ritus. Oh my goodness, we have somebody, let's see how many we have that know what nocturia is. Here's a definition of having to go at night and it interrupts sleep. That is urinating at night or bedwetting during the night that interrupts sleep or can cause skin breakdown. We have nighttime urination, and that came in from Kendall. Thank you. And we have another one. Nocturia is the need to get up at night in order to urinate, thus interrupting sleep. I think some people were working very hard on Wikipedia, or they looked that one up. Okay, well, this is just great. Let's keep following along here with S's, and we're almost done. I'll tell you, we're real close. You've been wonderful at hanging in there with me. We're going to talk about T through Z, so that means we are at the end if we're getting close to Z. I swear I'm going to learn to sing the letters through the Sesame Street and put up my characters for the next one with Cookie Monster and all. Toothaches are ignored often. I also want you to know that when we talk about appetite being decreased, sometimes this is the only reason and they can't tell us. Dentures, another issue, really rubbing the gums. Some of these people can have miserable issues there. I look at other issues with the mouth. I happen to be one of those people that suffers from canker sores when I have a lot of stress or I eat too many tomatoes. And I can hardly eat, and it's so miserable. And you know there are mouthwashes for that that we can give people to alleviate so much of that pain. Think of the discomfort that we can minimize. And anybody who's had a toothache knows how miserable that is. Urinary incontinence, we talked about already, but we didn't talk about retention. That is somebody who does not urinate, who fails to urinate during the day. This, folks, I mean, you can have ruptured bladders. It doesn't happen often, but it can, especially if we have somebody with a Foley catheter that is having retention. We're not having urine output. We really have to figure out what's going on and quickly. We don't have a lot of time to deal with urinary retention, the filling of the bladder without it being released. This was interesting to me last night. When I talked about vaginal bleeding and vaginal discharge, people came up with lots of reasons why we would have this, and they all recognized they should tell the nurse about it. But one thing that's often missed, and I don't care what kind of facility you're in, you can be in the Taj Mahal of facilities, vaginal bleeding or discharge can be a sign of sexual molestation or a rape. And I don't think this is something that can ever be dismissed. So if you see this, you want to make sure that you're having someone else be involved with this, because this could be a sign, and it can have some tremendous. And this is a situation where you want to talk with the resident. You want to make sure what's going on in your facility. So this is a very severe thing to be looking at. And we've done some other work on this, and there's going to be a program coming up on that very soon. We talked about vision, so we won't have to go through that again. Vomiting blood. Vomiting at all, we talked about we wanting the nurse to see. But also, if somebody vomits something that's called like coffee grounds, we want that looked at as well. This is why we don't want somebody cleaning up before the nurse gets to assess. We have weakness. Of all the symptoms that is so general, this is the one, whether they're weak getting up out of bed, falling asleep, a lot of lethargy, somebody who has a sided weakness. This can all be a sign of a transischemic attack, a TIA. It can be a stroke. It can be a urinary tract infection. Weakness on any part of the body. This just has to be reported and very clearly defined. So you don't want to just call the doctor and say the resident has a weakness. Is it on one side, both sides, a general kind of lassitude weakness? Are they unable to use their legs? Be very clear on this one. And then any kind of wound at all has to be reported. I can't tell you enough how important it is for nurses to be teachers for CNAs. Teach them about the meds the residents are on and what are adverse effects. Teach them about conditions. Teach them everything you learned today, everything you watched, not all at one time, but be a teacher as you do your job. Teach all the time, and you will have one of the best teams that you can imagine. Your CNAs will respect you. You're going to have way more information. Your job is going to be easier. Nurses need to teach. Nurses must listen. They must listen to the residents. They must listen to the CNAs. They must listen to the activities coordinators, to anyone that wants to share about the resident. It's hard. We have limited time. I am not a dreamer. I'm in this field and said I would always teach to reality. But nurses have to teach and nurses have to listen. And nursing assistants have to observe. They've got to watch. They've got to be the eyes, ears, nose for these residents. And nursing assistants must report and report and report because they have to keep telling the nurses sometime. And I work with nursing assistants a lot to teach them that if a nurse is on the phone with the doctor, has somebody getting them to sign something, a resident or a family member's at the desk, and then the aide says or a nursing assistant says, Mrs. So-and-so isn't feeling good and she's got a temp. That may not be the best time to tell that nurse. But you know what? You got to go back again. And you don't have to be ugly. You don't have to go back and say to the nurse, did you check her? Were you listening to me? It can be as simple as, I know you're really busy. We need to be kind to each other. Nurses shouldn't be calling CNAs, do you think you're a nurse? Wouldn't you get your nursing license? And nursing assistants have to be respectful of the nurses. I watch it both ways. I lose my temper. I get frustrated. I know we're never supposed to. We're all human. But this has to be a situation where we all are listening and all are respecting each other. Housekeepers, dietary aides, activity coordinators, don't underestimate any member of your team. The housekeepers many times are finding the feces on the floor. They're seeing the blood in the toilets. They're seeing things on the linens that we may have missed. The activities coordinators know when somebody could play a great game of bingo yesterday, but today they can't even see the card. Nobody should be dismissed. We truly are a team. The more that we work as a team, the more we cooperate, the better chance we are of preventing those unwanted admissions to hospitals, situations where people don't get bathed for days or have skin breakdown in moments. There are going to be residents, there isn't anything we can do to prevent them from going to a hospital or an ER. But for the most part, I think we can be much more proactive. So in conclusion, on reporting our conditions, this was A to Z, and by gosh, we did do a lot of them. I want to ask you please to do the evaluations. If you need copies, don't be very comfortable doing it. Remember, up in the upper left-hand corner, you've got the little paper clip. Click on it. Burn out a copy, make copies, print a few for me. But this is the way that we're allowed to be able to continue to offer you this programming, is by getting these evaluations in. We want to know what you want to learn. We want to know the truth. Are you enjoying the presentations, or is there something we can do or something that we're not presenting? We want to know what that is. Most of all, we want to thank you for joining us today, for being at the Elizabeth McGowan Training Institute. And if you have any questions, we still have a couple minutes. I'll wait and see if any other questions or comments come in for a second. And otherwise, we'll end our Friday afternoon. And I know other people may watch this at another date. But it is a beautiful Friday afternoon in San Antonio, crisp and cool. And when we're teaching to you in the hot summer, I'll be talking about this day. So thanks to all of you for joining us. I'm going to stay here for just a couple more minutes. And you're free to leave, or you can go ahead and send us your comments about the class today. Thanks so much. See you soon. And don't forget, you can take classes also online for emergency conditions in geriatric residents, for contact hours, aggressive behaviors with dementia, documentation. We have a boatload of programs where you can get contact hours. This wasn't one of them today, but we do offer lots of those. And let us know which other ones you'd like. Thanks. Do we have other questions, Dayon? Okay. Okay, we're going to finish up again. Thank you for joining us. Bye-bye.